Your slides are on, and now your mic is on.
Well, let's do it.
It's all you.
All right, guys. I'm Shane. I'm a PGY3 over at Freeman. We're going to talk about altered mental status today. Not diving too deep. A lot of this is kind of just superficial level of knowledge. Just kind of in the EMS setting, kind of carrying over into ER a little bit. Things that we need to look for, things that are important information to convey to ER docs. So really, you get a lot from general appearance. So, even in the ER, in a lot of our board exams, we start off with, I walk into the room, what do I see? You get a lot of information from that. It's the same thing out in the field. So just, you can observe their overall general appearance, like what is their hygiene? How are they dressed? Are they cachectic? Are they chronically ill appearing? Or are they taking care of themselves? Observe their verbal and nonverbal behavior, simple things like facial expressions, their tone of voice. Do they have a weak tone of voice? Is their speech garbled? Can they communicate with you? Are they able to make eye contact? Things like strokes, encephalopathy, even psychiatric illnesses. Some of these patients that are altered can't even make eye contact with you. So that tells you a lot. Quickly, is their memory intact for recent events, long-term events, and can they be focused? Can they have your attention fixed on something, or are they kind of all over the place, tangential speech, and they're not making sense? You get a lot of information just from these things. Orientation. That's the first thing when I think a patient is altered. I stop any history taking and I ask them orientation questions. So, we say, A&O times 3, A&O times 4. I don't think that conveys as much information as saying, what are they oriented to specifically? Person, location, president, month, year. Those are typically things that I start with and always ask direct questions. When I first started off, I got into the habit of saying, open-ended questions. Do you know what month it is? Do you know what year it is? And sometimes you'll get yes, and that's not helpful. So, I always say, what is your first and last name? What month and year is it? Who's the president? What city and state are you in? That seems to get me the most information. And this is important to obtain in the field on initial contact, because this process can be evolving and it'll give you a good picture of where they're at in the treatment as well. So if they're getting better with simple medications, fluids, antibiotics, it gives you more information as well. And then getting a baseline, especially from family and friends or the facility, is huge for us. So a lot of times, this could be the first time we're seeing this patient. We have no idea what their baseline mental status is. And then last known well, really important, especially because the differential for altered mental status is so broad. Sometimes it could be a stroke, and that makes a big difference as how we treat and where we send these patients. This is just a quick thing to do, this AVPU mnemonic. We look for alertness. So alertness is eyes open spontaneously. And then the key is for alertness versus being awake is that they're aware and able to interact with the environment. So somebody that is in a catatonic state, they can have eyes opening, they can appear to be awake, but they can't interact with their environment. And then just a verbal response, can the patient just speak to you? Do their words make sense? Responding to pain. So we kind of go down this as far as being alert and then being completely unresponsive. So, obviously, a patient is flaccid with no responses at all. That's not good. So how do we appropriately stimulate a painful response? I'm sure you guys do this a lot in the field, but it's applicable to us in the ER. Be surprised how many interns don't really know how to do this. So pressing on the supraorbital ridge, trapezius squeeze, sternal rub, pressing on the nail bed, and then Dr. Nuring loves this one. So, basically like you're doing a jaw thrust to open up the airway, just crank on the angle of the mandible. That gets a lot of patients to respond pretty quickly, especially if they're playing possum. So I like that one. That's my go-to. I learned it from Dr. Nuring. So what is altered mental status? So any of these states, right? So they're not awake, they're not alert, they're not oriented, they're just confused, or they're unable to demonstrate an understanding when they normally would. So a lot of times you just do a teach back. So we'll have a quick communication and then summarize what I just told you. They can't summarize that. They're probably altered. They probably can't participate in their own medical decisions at that time. So level of consciousness, a lot of this is related to the metabolic state of the brain, and a lot of it related to perfusion. So one of the first indicators to change when the level of perfusion to the brain is decreased is consciousness, awareness, able to interact. So the most important takeaway from this lecture is a differential diagnosis for the cause of altered mental status. And we have some of these mnemonics. I don't really like SMAShed as much as the first one, the AEIOU tips. So reason being, this is so broad, and if you can't think about it, you can't diagnose it, and you can't treat it. So a lot of this lecture is going to be focused on this. So this just allows us to kind of have a broad differential, think outside of the box, and even if you find one cause, there may be others. And you find that a lot, especially in the ER once we start digging through stuff. So this AEIOU tips, it's alcohol, endocrine, electrolytes, encephalopathy, kind of just a general term that, you know, a lot of things fit in that bag. I, insulin, O, opiates, U, uremia, and then T can be trauma, temperature, things like that. I think about like head injuries, blood loss, shock, cold exposure. A lot of that will be obvious on scene. I, anything intracranial, when we were talking about, you know, masses, abscesses, meningitis. P, poisoning, psychiatric illness. And then S, seizures, and then even syncope. And I put syncope on there because sometimes it's hard to differentiate between seizures, because even with some vasovagal type syncope and even cardiogenic syncope, you can have you know, mild tonic activity that mimics seizures. So I just put that in there briefly. And then this other one, SMASH, I mean, substrates, talking about metabolic things for the brain, sepsis, even, you know, thiamine being important too, and we'll talk about that later when we start talking about alcoholism. And meningitis, mental illness, alcohol again, seizure, stimulants, hypothyroidism, temperature again with hypothermia, hypoxia, that one's important, hypercarbia, we see that a lot, especially, you know, a lot of our patient population is not the healthiest, a lot of obesity, you know, we get Pickwickian syndrome where they're, you know, retaining all that CO2. They come in, they're just gorked, and that, you know, that's the only thing. Their CO2 is 120 on their VBG, and put them on some, you know, BiPAP, and they improve pretty quickly. Electrolytes, and then encephalopathy again, and then drugs of any sort, even prescription medications. You get a lot of side effects, a lot of drug interactions. You know, you get these 75-year-old, 80-year-old patients that are on 30 different medications. So just a lot, you know, things to think of in the back of the head. It just helps you kind of get to the bottom. So when we talk about alcoholism, two of the big things that we got to think about in the ER and even in the ICU, I've had a few of these patients admitted to the ICU, young patients too, you know, 40s, 50s. We talk about, you know, Wernicke syndrome, and then it's, if it goes undetected and it's chronic in nature, becomes Korsakoff syndrome. So Wernicke syndrome, you kind of get this triad of encephalopathy, ocular motor dysfunction, and ataxia. So the encephalopathy can present with just, you know, disorientation, indifference, inattentiveness. So when we talked about, you know, in the beginning, is the patient able to focus on you, focus on the communication? You know, this is kind of a way to point you in this direction, especially if they have a history of alcoholism. And then the big thing is nystagmus with these. I mean, you can have some palsies and things like that, but these patients typically have nystagmus. And then just their gait is off. You know, they could complain of, you know, I can't walk to the bathroom. I feel like I keep falling into the walls. And then the treatment for this is thiamine. These patients are deficient in thiamine, often due to their diet, because they're strictly consuming alcohol. And they're deficient in calories, they're deficient in vitamins and minerals, and the brain needs thiamine to work appropriately. So that's your B1. And then if this goes on long enough, if, you know, they don't have family members, they don't have friends that check on them, they just stay at home, they don't seek care, this can progress into Korsakoff syndrome, where you get this confabulation, amnesia, and they're just completely altered from their baseline. And, you know, sometimes we see the patients at this level, and really all you need to do is give them thiamine and magnesium. And also, due to the diet, these patients are very deficient in magnesium, and a lot of times they drink themselves into having, you know, bouts of emesis. So you're going to lose magnesium that way, lose it in the stool as well. And actually, the patient that I had in the ICU had this, and he actually had seizures from it, and he was severely deficient in thiamine and magnesium. And the treatment for this is crazy high doses of thiamine over days. And they turn around pretty quickly, but once they get into this Korsakoff syndrome, it can be irreversible. So that's why you got to get on it quickly. And when you have alcoholic patients in the ED, always thiamine. Every patient that comes in, thiamine, because you're going to eventually, be feeding these patients, giving them, fluids that may contain dextrose, and you can actually induce this if you do that before you give thiamine. So endocrine, I mean, we see this all the time, right? So this is one of the more common causes of altered mental status. We talk about, so many of our patient populations have diabetes and thyroid disorder, especially when we start getting up in age. So, hyperglycemia is basically, inability to utilize glucose efficiently. Your cells can't take it up, can't utilize it for energy. You go into ketosis. And I thought this was just interesting. This is something that we think about a lot in the ER. Dr. Bingman likes to pimp everybody on this. So the fluid deficit in DKA is huge, right? And this in itself is going to contribute to that perfusion that we talked about earlier. So not only are these patients not able to utilize glucose, and they're going into ketosis, the brain doesn't like using ketones. It's dependent on glucose. And their fluid deficit is 6 liters in DKA up to 12 in HHS. So these patients come in, they're just dry, altered, look like crap. And even this hyperviscosity, more related to HHS, because you're getting glucose levels well over 1,000 most of the time, is going to increase your risk of or cause stroke or MI. And even patients that have chronic deficits, we get this a lot where they come in with stroke-like symptoms, where they get worsening of their chronic symptoms. So maybe, they had slight mobility, slight use of their arm, and then all of a sudden they can't use it at all. They come in and get stroke protocoled, and nothing acute on any of our imaging, and it's just related to having a blood sugar of 1,300. So, obviously, you guys do this on a lot of the patients, but checking up POC blood sugar, we recheck it. A lot of times, even when they come in, just give us a new baseline too, especially if you guys gave them fluids. And why do we do this? Because it's most common and it's easily reversible, right? Especially if it's low. They took too much insulin or something like that. Another thing is, as far as endocrine goes, we talk about thyroid. So there's two opposite ends of this spectrum: myxedema coma related to hypothyroidism, and then a thyroid storm. And those patients are going to have a underlying hyperthyroid state and then an acute stressor, but we'll talk about that on the next slide. So myxedema coma, basically a severe form of hypothyroidism, untreated. They don't have any T3, T4. They have no active thyroid. So there's all of their cells, their metabolic state, nothing's ramped up. Everything's way down and nothing can function appropriately. So everything, you just think this is a big downer. Everything's down. These patients look like crap. Their hair is thin. They got puffy face. They got this, basically these glycans that are stored everywhere, and their face looks all puffy. Their intestines aren't working. They're constipated, bradycardic, poor appetite, obese. And then you get all these precipitating factors, right? So they're not treated for their thyroid, and then they get some sort of infection, cold exposure, stroke, anything that stresses out the body, and the body can't respond appropriately. And things we look for in the labs is hypoglycemia, hyponatremia. These patients can be hypoxemic or hypercapnic. They get all these QT and ECG changes. And then really management is just supportive. So, these patients may even need airway support because they can be comatose. So not surprising to find that in the field, and these patients have to be intubated. They need steroids, and really they just got to get T3 supplementation, and they respond pretty good. Now, if we look at the other side of this spectrum, thyroid storm. So this is a hyperthyroid state plus an acute event, kind of similar to the previous slide. One of the more common ones being Hashimoto's thyroiditis. The thyroid gland is just inflamed, pissed off. It's pumping out a lot of T3. And they come in, they get a surgery, they just got some illness, and they come in, they just look like crap too. So their heart rates are through the roof. And the big thing with this is that it can cause high output heart failure. So your heart can only beat 140 beats plus per minute for so long. before it starts to just give out. So a lot of these patients come in with heart failure, they're hypothermic, they're agitated, they can be they can have psychosis, stupor, coma. So similar thing, they may need airway protection. And the most important thing is giving a beta blocker. So that this treatment is a list in order of importance. So beta blockers shutting down that peripheral storm essentially. So that's going to help with the heart rate. It's going to help with a lot of symptoms. Then everything else kind of comes into play later for more long term. All right, electrolytes. What patients do we have to worry about for this? So these are going to be our renal patients and then elderly patients with GI volume loss. We get a lot of patients that are on antibiotics a lot. It's not uncommon to see them with C. diff or anything, some E. coli, salmonella. We see that a lot. Even Campylobacter we've been seeing a lot. I'm not sure why recently. I've seen 3 or 4 patients with that. And the big things we got to worry about is sodium, mag, phos, potassium, and calcium. Those are the big ones that get thrown off, especially potassium in our renal patients. You can see some changes on ECG, and that's going to clue us into having to treat that even before labs come back. And a lot of times we'll get a POC labs on these patients just to check their lights when they come in. So this is related, especially with the elderly patients that have diarrhea, especially dysentery, so that bloody diarrhea with Shiga toxin producing E. coli. So this is TTP, thrombocytopenic purpura. So you get this triad that's related to HUS that kiddos get, where you get this this microangiopathic hemolytic anemia because you're basically your cells aren't functioning right and they're getting lysed. So you get all this microvascular damage, and it starts to affect the kidneys, it starts to affect the brain, and you get renal failure, you get neurologic symptoms, and often fever. So I actually had one of these patients that came in. She was 75. She had dysentery, acute renal failure without a history of kidney injury ever or chronic kidney disease. And this was on the differential diagnosis, talking to the hospitalist. And we had to send this patient over for plasmapheresis. Pretty interesting case, cause of altered mental status. And this was one of those kind of weird ones where she lived at home alone, but relatively healthy. Son went to check on her, hadn't heard from her in a day or two, came in really confused, febrile, acute kidney injury, creatinine of like 5 or 6. And yeah, she had to get transferred for plasmapheresis. So, I mean, there's weird things out there that cause altered mental status. Yeah, and this is all really related to platelet dysfunction from the Shiga toxin producing E. coli. So, encephalopathy, this is just a big encatchment term, right? So this is just really a syndrome of brain dysfunction with many causes. A lot of the ones that we're going to see, hyperammonemia, so our alcoholic patients, their ammonia levels are through the roof. They're not taking their medicines like they should be. And then uremia, especially these patients that have new onset kidney failure, their body hasn't adjusted to these very high levels of BUN. And the brain doesn't like it. It's a toxic metabolite, right? So these patients get encephalopathic. And then there's just other things, exposure to toxins, radiation, even if they're getting treatment, poor nutrition, hypoxia, just a lot of generalized things, but the hallmark being altered mental status with brain dysfunction. And, it can be subtle at first too, just subtle personality changes that family members notice. And then they bring them in. So insulin, this is a big one, especially patients when they're first getting started on insulin. Their glucose levels can fall pretty quickly until we titrate that. That's why a lot of times in the ER, we don't like to discharge or start patients on insulin, especially if they're insulin naive, just because the risk of causing hypoglycemia and actually death is pretty significant. So we like to admit these patients to the hospital. But it's not uncommon to see patients coming in. They're ill. They haven't eaten in a few days. They're still taking their same glucose or insulin that they're supposed to be taking, and they come in with blood sugars of 40 and 50. Another thing that is related to this, not necessarily insulin, but your PO medications. A lot of times patients will accidentally take too many, and the half-life of them are pretty high, the sulfonylureas. So we have to admit all patients that come in that have hypoglycemia that are related to those PO agents, just because the half-life is so high. If we fix their blood sugar, send them home, they're going to come right back, or something bad can happen. So yeah, all patients with altered mental status, check their blood sugar level. Opiates. I just thought this was interesting. This came up in one of my Roche review board questions. So, which medication can mimic opioid overdose without the pupillary constriction? That's actually clonidine, which I thought was interesting, and you can try to treat that with high doses of Narcan. So they'll have kind of all the depressive effects of opiates, but without pupillary changes. So kind of a cool one. I think we all know the signs and symptoms here. Let's talk about that. So uremia again. So this is a waste product, like I talked about earlier. It's a toxin to the brain, especially. The only thing I want to talk about here is early symptoms. So especially when patients that they have normal kidney function normally, they start to get anorexia and lethargy prior to having this decreased mental acuity and coma. So those are some of the first signs that you can see. Trauma and head injuries here. So really the two that are more common, ones I really want to touch on here, epidural and subdural. What's interesting about the epidural is the lucid interval. So a lot of these patients will be younger patients. They get a head injury. They're likely knocked unconscious, but then they improve, they feel well, and then later they acutely decline. So one of the board prep materials that I was looking at called the talk and die phenomenon. So they're up talking, they make sense, they're oriented, everything sounds good. A few hours later, they get that increased intracranial pressure from the bleeding that's continuously bleeding in their brain in the epidural space, and then they get a shift and they die, herniation. So that one's kind of scary. And then your subdurals, we're talking about slow bleeds with subtle changes here. Where you got to worry about alcoholics in the elderly. Kind of an interesting case I had just 2 weeks ago, actually, right before I went to New York for vacation. Old guy came in. This was actually a shift change patient. Those are always that's the worst. Shift change will screw you every time. So going in and reassessing the patient, and he was communicating with his phone through text because he couldn't speak. So he would type some things and then show us. And it was reported, or somebody thought, I'm not sure where it came from, but that was his baseline. And then just prior to admitting the patient, a few hours into the workup, family came in and they said, oh, what we were really concerned about was that he was choking when he ate and then started having difficulty speaking, and then yesterday just couldn't speak at all. So that kind of changes things. That wasn't his baseline. He ended up having a brain bleed. So nothing that we really needed to do anything about, but you miss those things, it's a big deal. So again, baseline, important. Intracranial tumors, abscesses, chronic conditions, so chronic alcoholism. Alcoholics, and that's a big thing. We get a lot of alcoholics that come in all the time, but they will screw you. So just assume they're sick every time they come in. So, if they said they had a fall, CT scan. You don't try to reason your way out of it. Just do the workup. I think I have another one here. Okay, so we had a 12-year-old that came in for altered mental status. He was febrile. He was really dry. Was not really wanting to take PO intake. Was completely disoriented. Wasn't making sense. You'd ask him a question, he'd just say some random thing unrelated. And family said that he was progressively getting worse over about a week. And we do the altered mental status thing, and this is his CAT scan. So we have these ring enhancing lesions here on both sides. Typically when it's ring enhancing like that, you're going to think abscess formation or toxoplasmosis. So he had brain abscess. So he had to ship him up to Children's. He got a craniectomy and washout, and I think he's doing better now. But and it's surprising. I saw that a lot on my Children's Mercy rotation. You get these abscesses, and they get washed out, and they do pretty well. I mean, the brain's still pretty plastic at that age, so they recover pretty well. Infection, UTI, man, that's like when we see that almost every shift, right? We get these old people coming in, they're just not at their baseline, altered. It's a UTI until proven otherwise. So A lot of other things, you get post-op complications. You see that a lot, especially with belly surgeries. A patient had a hernia repair or something. They get a little abscess formation or something in there. They get sick, they get septic, especially when they're not on top of it and they don't come in. And I always think it's funny. First question you ask when these patients come in is, did you call your surgeon? Answer is always no. And then a big one too, I've been trying to be better about this lately, especially old altered patients when you can't find the source of why they're like that. Sacral wounds, commonly missed. Nobody wants to turn these old people. A lot of times, from the facility, you don't get good communication on that. But I've been starting to check, especially when I don't have a source, check the bottom. A lot of times it's that. They got a stage 3 sacral decube and they're just septic from it, and they got osteo and they just look like crap when they come in. Altered. Poisoning. See this pretty frequently too. Sometimes it's intentional, sometimes it's accidental, and frequently in the peds population, accidental. Again, at Children's Mercy, I saw 3 or 4 of these in typically 2 to 5-year-olds. Where they're starting to explore things. They get into THC. A lot of times it's gummies. They see it, it's candy, tastes good, they eat it. And this can actually mimic brain death at high doses on your physical exam. And I mean, completely non-reactive pupils, no response, intubated, don't need sedation. EEG can actually be abnormal as well, and then spontaneously recover after the half-life. So crazy. And then for us, what's helpful is bringing all containers, and you guys are usually pretty awesome with that. Just helps us kind of know, especially with these intentional ones. I mean, these patients are just taking anything they get their hands on. So, and they're not going to be truthful with what they're taking. So the pill bottles help, especially if they're, right there on the scene and they're open. How are we doing on time? We're good. Okay. Again, related to the poisoning, I think this is pretty relevant out here with all the farmers, especially when they use pesticides, is your organophosphates. So these poisons, they bind cholinesterase, so you can't break down acetylcholine. So basically you get this surge of PNS symptoms, and you get these symptoms of dumbbells. I like that better than the sludge mnemonic over there, but they have diarrhea, basically everything wet, right? So diarrhea, urination, meiosis, the tearing eyes, lacrimation, salivation. They can get seizures. Everything is just wet. Their PNS system is way ramped up because acetylcholine drives that. And then you get the killer bees, so bradycardia, bronchospasm, and bronchorrhea. And those can be real bad because the patients can't protect their airway. And the treatment for this is just atropine, atropine, atropine all day. Just keep giving it till their secretions dry up. But that can be a fatal one. And then lead toxicity. This comes up all the time on board. So both of these are from Roche Review, the board review that we use. Lead toxicity, especially when it's chronic. So they get these subtle changes in mental status, these kiddos, especially with some of the old houses around here that may have some lead paint still. And I think of bees. So brain, bone, blood, and belly is kind of the symptoms for lead toxicity in kiddos. Those are all the symptoms or systems affected by that. So again, altered mental status in kiddos with lead toxicity has got to be on your differential. All right, psychiatric. I don't see too much of this because we have yellow pod, but we do still have to clear a lot of these patients. And schizophrenia, not as common as bipolar disorder is from what I've seen, but some of the material said that overall bipolar disorder is actually less common than schizophrenia in certain regions. But I've definitely seen a lot of these patients with manic episodes. So they come in, they're just all over the place with their thoughts and their speech. They're talking really fast. We'll go right here. So basically these are all the symptoms. So they can appear to be altered from baseline, and it's really just related to their psychiatric illness. That can be treatable, but they're distractible, they're impulsive. Talk about this grandiosity where they think they're better than everything. They're like Jesus, they're the king of the world. Then the flight of ideas where they're just talking over here, they jump to the next thing, they jump to the next thing, they jump to the next thing, and you can't keep them focused, right? And they're hyperactive, they're out there doing a million things, spending all their money. and then they're not sleeping. So, I mean, these patients act like they're on uppers, but it's just related to psychiatric illness. And then just back to schizophrenia here, the hallmark just being your loss of contact with reality, essentially, right? So hallucinations and delusions is kind of what defines a schizophrenic episode, right? So they'll see things, they think people are following them, they hear voices, talking to people that aren't there. That's yellow pod. Go to yellow pod. Seizures, see this all the time, right? So what's the underlying cause? Some of these patients just have epilepsy. Maybe they're an alcoholic, maybe they fell, maybe they're withdrawing from alcohol, or maybe they have a head injury or both. So a lot of things that you got to look into, and their history of presenting illness will kind of guide that. This, I've never seen isoniazid toxicity. I don't know that I ever will see it, but it comes up on boards all the time. So they get this B6 deficiency with isoniazid, and they'll have refractory seizures. Doesn't matter what you give them, doesn't matter what their glucose is, doesn't matter how much Ativan or Keppra you give them, they're going to keep seizing until you give them B6. So history being very important with that type of presentation. And then obviously hypoglycemia, that's why we check it, that's why we treat it. And then this one, see this more frequently than I thought I would, hypertensive crisis. So these patients can come in with focal neurologic symptoms, altered mental status, things like that. I think I have a slide up. Yeah, Press syndrome. And Press syndrome is related to hypertensive crisis. And then as far as seizures go, they can have Todd's paralysis, right? Symptoms lasting hours. They're gorped, they're altered, they have focal deficits, and then spontaneous recovery. So a lot of weird stuff out there. This one's actually really cool. I've seen this multiple times in the ER. This Press syndrome is posterior reversible encephalopathy syndrome, right? And it's there's other causes, but a lot of times when we see it, it's related to this hypertensive emergency. And the occipital and parietal lobe are commonly affected here. So they get a lot of changes in vision. They get changes in speech patterns. They can get focal weakness. And really it's just this, focal white matter changes where you can see on the arrows there related to posterior circulation. They get these white matter changes, and the brain literally is just dysfunctional from prolonged high blood pressure. So you treat them, and like the name suggests, it's reversible. You treat the blood pressure, you put them on blood pressure medication, outpatient, they get better until they stop taking their blood pressure medication. Syncope, the only reason that I put this up here is because sometimes it's hard to differentiate from seizures and altered mental status. You can have, myotonic activity just from a vasovagal syncope episode, and patients come in, they're like, oh, they had a seizure and it was witnessed and all that, and it ends up being a whole lot of nothing. The overall cause of syncope being related to brain perfusion. So for a brief second, there's a loss of brain perfusion that causes, collapse. The only thing that we care about for syncope really in the ER is if it's cardiovascular, right? Is this a dysrhythmia causing it? And this is where you get that drop syncope. A lot of these patients need to be worked up, especially your old guy that came in that says, I just fell out. No symptoms, nothing, no warning symptoms or anything. All right, so we see this a lot too. Dementia versus delirium comes up a lot on boards too. Big differentiators being the time frame. So dementia, more of a chronic, slow, progressive, indolent process. And typically it's irreversible. They have impaired memory. They have cognitive deficits. And a lot of times it can be just from microvascular insults to the brain. Just vascular disease related to hyperlipidemia, blood pressure, diabetes, things like that. Chronic things that go on a long time untreated, especially. Alzheimer's disease. And then contrast that with delirium. Typically this is rapid onset. We're talking hours for the most part. It's fluctuating where dementia is typically fixed in its course. And these may be reversible, and that's why it's our job to look for it, right? So what's the underlying organic cause? What's causing this patient to be delirious? So we kind of talked about this already. So dementia, this progressive disorientation, strokes, atherosclerotic disease, age-related neurologic changes in the brain, hereditary things, Huntington's disease. There's many others, but a lot of that stuff you're not going to fix. You can diagnose it, you can't fix it. Delirium. So we talked about this too. So rule out the underlying organic cause, right? Look for reasons. Is it simple? Do they have UTI? Is it just because they're hospitalized? They're in an environment where their sleep-wake cycle is off because they're getting woken up every 4 hours for vital signs, just simple things like that. New medications, anything. All right, talk about GCS. We do this a lot in the ER, and it gets a little bit detailed here, and I won't talk about it too much, but basically you want to give the patient the best score possible, right? So if they can move the right extremity but not the left, just give them the credit for being able to do that and follow commands. And the reason we do that is because when they deteriorate, it's a little bit more sensitive, so you'll catch that deterioration sooner rather than later if you're giving them credit for a higher score off the bat. Then the pediatric component too, this is hard because a lot of times they're not verbal, so getting that accurate verbal response can be difficult, but we'll talk about that real quick. We all know this, EVM 456, your eye-opening verbal response, motor response. I think when I first started doing it, the verbal response and the motor response were a little bit more difficult than eye-opening. So verbal response, I had a difficult time in the beginning with scoring them a 3 or a 2. But I think this does a little bit better laying it out because, I mean, you know the difference between inappropriate words related to the conversation versus it's just incomprehensible mumbling noises that aren't even formed words. So I think that was helpful here. I think we're pretty good with motor. This kind of just gives us a generalized idea of brain dysfunction, oftentimes related to injury. Get this score a lot in trauma. I mean, we don't really care. It's just an arbitrary, how dysfunctional is the brain. But I mean, nobody's saying mild or moderate brain injury. The GCS alone can tell you that. Only one that we really care about is the 8, right? So it's 8, intubate. Yeah, we don't need to talk about this. So we'll talk about the pediatric component a little bit. So just a helpful way for, verbal response in nonverbal pediatric patients. So give them a 5. They can smile, coo, follow objects, things like that. Irritability, but they're consolable. That's another one. So when we talk about sick kids in the ER, if it's anything even simple, they have upper respiratory infection, but they're not eating, they're not drinking, they're febrile. Irritable but consolable, a lot of times I'll put that in my documentation. And if they're inconsolable, agitated, they're just moaning or groaning, that's a sick kid. That kid needs your attention. Then obviously if they're completely lethargic, non-responsive, that kid gets everything. But a lot of times I put that in my documentation because a kid can be sick, they can be irritable, but you can console them, and those kids can oftentimes go home. Yeah, we're good with that. We won't talk about this. If we have time, we can go back. It's just examples. We don't need to do that. You guys do this, right? This is what you use? Cincinnati stroke scale. So this is a quick one. I don't really like the NIH score. I don't think it's all that helpful, to be honest with you. Everybody does it. It's standard of care, and I don't really understand it because it's not that useful unless your score is crazy, greater than 25. That excludes them from TPA. I think that's where it's useful for me. But a lot of times this will change. 3 patients go in the room, or three providers go in the room. You get 3 different scores. It's not all that helpful to me. I like this. It's quick and dirty, right? It's simple. You can do it anywhere. It's pretty reproducible between providers. So I mean, facial droop, arm drift, speech. Those are all very obvious things that you can look at to see if this patient has, stroke-like symptoms. So easy, right? Smile real big, show me your teeth. They have to put in good effort when they do this, right? So I always say, give me your best smile, big, 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 big smile. And a lot of times I smile with them because, if they give a little crooked smile, it's not going to help you at all. So smile, show your teeth, make them really do it. Other things you can do quickly, stick your tongue out, close your eyes real tight, just see the symmetry in the face. A lot of times this is only the things that I'm looking for off the bat. Pronator drift, got to hold the arms straight out for 10 seconds. So that 10 seconds is important because they got to get a little bit fatigued. You got to fatigue those muscles, see if they drift. Clarity of speech, right? Ask them just to say something simple to you if it's not obvious off the bat when you're just getting history from them. So something you can't teach an old dog new tricks. Just have them say that back to you. It's easy to do. But yeah, I like the Cincinnati stroke scale. Quick fixes. I thought this was a pretty good slide here. So, give them sugar. Hypoxic, give them oxygen. Pinpoint pupils, Narcan. Seizures, Valium. A lot of this stuff is reversible if you recognize it, treat it the right way. A lot of things I forget about too, and a lot of times the techs don't communicate well with us sometimes as far as temperature. A 95, a 96 degree temperature is clinically significant, right? So if we're getting slammed with 3-4 ambulances and we didn't go back and check a temperature, or 2 more sets of vital signs without a temperature went in and we didn't go back and we missed that, warm them up. Is it their thyroid? Are we talking about myxedema coma here? It all matters. Simple things. I like these. We won't talk about treatment very much, but it's just quick little case studies here to kind of trigger your brain. What's your differential? I like to run through stuff like this all the time. It's kind of like Roche review based, but 57-year-old patient found behind the garage unresponsive. He's breathing, has a radio pulse, dry blood on lips. What are your impressions, right? So this is where we start getting into the differential diagnosis. Some things that you could think of, right? Post-ictal from the seizure. Did he fall? Did he get facial trauma? That's why he's got blood. Did he drop his blood sugar? Is he a diabetic? Is he just intoxicated? Is he behind his shed doing drugs? Did he have a stroke? Did he have a heart attack? Did he just have a head injury? Things like that. So this one, I like this one. This is a good one too. We see this pretty frequently. Patient comes in to the ED by spouse, was dropping silverware at lunch, unable to sit up straight, couldn't complete sentences, speech is abnormal. We get this EKG, show irregular rhythm here. So AFib, right? This is especially patients that don't go to the doctor often. They'll have AFib that's been going on for months to years. And if they're not anticoagulated, increases the risk for stroke, right? So I like this case. This is common. We see this all the time. AFib, they're not on aspirin, they're not on Eliquis, they're not on anything. They get a clot in the atrial appendage, goes up to the brain, stroke. But the thing is, a lot of these patients, if caught in the time frame, they have a large vessel occlusion and they can go for thrombectomy. And a lot of times they have really good recovery. But yeah, we'd still do all the things, right? Blood sugar, Cincinnati stroke scale. Yep. Last known well. We love that. Good last known well helps us so much. All right, 18-year-old patient found under the bleachers at school, unresponsive with shallow respirations. So with this quick AVPU that we talked about earlier, he responds to painful stimuli only. So this guy's sick. Pupils are constricted, GCS 8. What are your impressions? So drug overdose, right? Constricted pupils, depressed respirations. Maybe he was trying to be a cool kid at school under the bleachers, doing drugs with his friends, some sort of head injury. I mean, that one kind of always fits with altered mental status. Hypoglycemia. I mean, maybe this kid just had a new seizure for the first time. All the things that we got to rule out. All right, here's another one. EMS called to the scene for an unknown medical emergency. Police secured the scene. 54-year-old male who's combative. Right, we see this a lot. I mean, you guys always take in these patients. Cops are following right behind or bringing them in cuffs, and they're screaming and yelling and swearing. They go, where? Right to yellow pod. We like that. But, just underlying psychiatric problem. Is this schizophrenia? Is it bipolar disorder? Do they just have abnormal blood sugar? Because you can get combative patients. Head injury. I've seen plenty of time, patients that come in after a car accident and they're combative. They don't want to follow commands. They don't want to sit in the bed. They try to get up and leave, but they have no idea what they're doing. electrolyte imbalance, drugs, toxins. So again, I mean, every case that you go into kind of goes back to the AEIOU tips, mnemonic, just a broad differential. How are we doing on time?
46 minutes.
Okay. All right. Just got a couple left here. So 32-year-old patient found combative at work, unusual behavior for the patient. So this one's kind of similar to the one that we just talked about. Similar things, right? Hypoglycemia, head injury, drug, alcohol. I mean, people do drink at work. So I mean, we've had patients in the ER come in, coworker or boss said they weren't acting right, and they got drugs or alcohol on board. But again, I mean, we're always checking the blood sugar. We're rolling out other things, even if we smell alcohol in these patients. Full neurologic exam, probably a CAT scan. Ooh, blood sugar was 25. You guys treated it. Now he's alert and oriented. Repeat sugar 56. Patient wants to sign a release. Can EMS allow a release to be obtained? I don't know. I left that there. I wanted to ask you guys. Yeah. Just kick him out.
But yeah, a lot of times these, DK these days is a little bit different. It takes a little longer.
Yeah. As long as they're good and they.
Yeah, as long as they wake up and they can sign it true.
Cool. So do you usually go for like a D50 or a D10 like in the field? D10.
It's been our choice for that reason, yeah.
Okay, I like it.
D50 was very common, so just a very short time ago, maybe 2 years ago, not very long.
All right, so we can go kind of flew through some of this. We'll go through these first ones are kind of easy. I like this one, so we'll do. All right, I think the pediatric ones are definitely harder. These mess me up a lot on boards. Just some examples here. So 6-month-old, we're just doing a pediatric GCS. Infant's eyes flutter when touched, cries when gently touched, but's consolable, and withdraws when first touching the patient. So what do we think this GCS is? 11. Number 10 here, 9-month-old. We have other peds one, yeah. I think there's only 2 peds ones. So 9-month-old, eyes flutter when the IO needle is placed, moans during the IO insertion, and when the deformed extremity is handled. Patient pulls their arms tightly towards their chest, curling shoulders and wrists inward. So this is real bad, right? GCS really low, 7. So that patient's probably going to need airway protection at that point. I mean, if you're sticking a needle in a kid and they're not really doing much, they're probably not protecting their airway. All right, we'll do 6. I like 6 is a good one. Eyes open briefly when asked to open them. The patient moans weakly when being touched. Patient tries to pull away when care is being provided. So example, like starting an IV. So 9. That patient's sick, but probably protecting their airway. Have you guys seen this? The clonidine overdoses?
Probably, but may not have realized it.
At the time, yeah. I've had 2 of them.
Narcan doesn't work on that one.
Yeah, I mean, that's as poor support in the literature. I mean, it's really, really high doses, and really doesn't do all that much. It's kind of just to try and see if it works. But yeah, the literature doesn't support it that good. Yeah, that's everything I want to talk about. I don't want to harp on the rest of the stuff. Some resources. I use a lot of Roche Review. Yeah, that's it. Cool. Well, thank you guys. Appreciate it. That was kind of a superficial dive into that, but
You know, give them a few seconds to ask any questions.
yeah, sounds great.
They're about 20 seconds behind us as usual, so that's they can fire them off there.
Yeah. But this is kind of a fun one just because, you know, a lot of times you don't know what you're working with. I like it in the ER. A lot of people don't like it, but I mean, kind of dive into things. Yeah, play detective, see what's going on. You got to get history. You got to talk to family, talk to the facility.
Well, thanks again.
Yeah,
Last speaker of the deal.
it was awesome.
There's your little
Heck
gift
yeah.
for coming in.
Thank you. Well, I appreciate you guys. It's been fun. I like doing this. Yeah, I appreciate it. I like doing the ACS one a little bit better, but I was on vacation.
Y'all have a great. You got? Am I live?
Back on there. All right.
You good?
Yeah.
All right. What Jeff doesn't know yet is that we're going to do another short, quick video after this of a quick little update of everything. But you guys can catch it up later if you are all set and done with videos. So catch us up on the update here.